Our next session is focused on the genetics of pheochromocytoma, and we are very delighted to welcome Associate Professor Joanne Ngeow, Senior Consultant at the Division of Medical Oncology and National Cancer Centre, Singapore. She's a world-renowned clinician scientist. She does both research and clinical work, and she'll guide us through the genetic underpinnings of this rare tumor condition. Thank you, Joanne.
Firstly, thank you to Troy, ANAH, and SCRI for the invitation. Always nice to spend a lazy Saturday morning, being inspired by my endocrinology friends. Listening to, Bill Young earlier, I'm very much reminded that's the reason why when we manage hereditary endocrine predisposition conditions like this, it's absolutely critical. If you don't remember anything from my talk, it's absolutely critical to be working in a multidisciplinary team in terms of the management of these cases, because they can sometimes be quite tricky. So I'm very grateful for Bill's earlier tips and all that, because it's really good to actually hear that, and we sometimes don't have enough time to actually have those multidisciplinary meetings. So thanks for the invite. These are some of my disclosures. And along the way, I took off a few slides that I think was covered already by Bill. In this way, I think we'll catch us up on some time as well. I'm going to just spend 1 or 2 minutes. You already saw a paper that Dr. Young presented earlier about looking at the age presentation. And that's really the work of my former mentor, Professor Karis Ng, Helmut Newman, and Dr. Bill Young, pretty much driving the whole field of pheochromocytoma. And she's contributed tremendously to endocrine cancer research. I just want to pause here because she is actually a Singaporean born, and she's from this part of the world. And just 2 things, she passed away, sadly, just very recently. And for the whole of this year, I'm going to be doing an in memoriam in honor of her in terms of what she's taught me and how we've been able to build our service. And these are some of her quotes. So I actually am trained as a medical oncologist, but I then went on to get training, as I mentioned, from Karis in Cleveland on the field of cancer genetics. And one of the reasons I did that was because as a medical oncologist, I was quite frustrated that I wasn't able to really impact on actually getting patients to either have early detection or prevent the disease. And very often I was only treating them as in the metastatic stage. And I think it's important that in this audience, I think many of you here come from perhaps not the genetics background, that the goals of clinical genetics is really about enabling sort of gene-specific management, getting them a better diagnosis, getting them detected earlier, trying to avoid this in the family members. And I think that's underpinning a lot of the work that folks in this field do. Just in terms of hereditary susceptibility to cancer, I think everyone in this audience will know that we're talking about germline mutations as opposed to sporadic mutations that are found in the tumor. And it certainly depends on the gene, what the risk is for a certain tumor or cancer subtype. However, someone who has actually a pathogenic variant in one of the cancer predisposition genes does not actually mean that they will definitely get cancer or tumor or pheo or whichever tumor type it is that you're interested in. It's really just a probability, a likelihood, a relative risk. And so you can see here in this graph that we often show in genetics, what we have on the y-axis is really allele frequency, which is essentially how common something is in the population. So you can have a lot of changes in your genetic sequence that is common in the general population, but actually have very low or minimal impact in terms of disease risk. And so that's this group here, what we call common variants with very low penetrance. And then you have on the other flip side, and some of the variants that Professor Young has just mentioned belong to this group, which are very rare variants in VHL, in SDHB, SGHD, etc., but very high penetrant, in which case we really want to act on them. Some of the list of additional genes that have been more newly found at the moment with regards to pheo and paraganglioma, we're still not quite sure, because the data is not yet quite mature, where it lies in this curve. And therefore, at the moment, for clinical management, the newer genes are actually we don't actually know how to clinically manage them. And so for the purpose of the rest of the talk, I'm only going to focus on what we call the clinically actionable things, where we have very clear guidelines in terms of how we're going to manage them, which typically falls in the rare variants, high penetrant group. So I think earlier on, Prof Young's already mentioned that pheochromocytoma, paraganglioma, the guidelines are all, because they're so uncommon, is to test every single one of them for a likelihood of germline predisposition. And I would say that I'll show another slide later on other neuroendocrine tumors. It doesn't apply across all the neuroendocrine tumors. It's for Pheo very much so, because up to 40% of them could have a germline mutation. Other red flags that we often use are early diagnosis, and I think in Pheo you saw earlier that graph where in the under 20s or the first and second decades, more than 70% of them might have a likely germline mutation. And when you got to the other end, which is above 60 years old, less than 2% of them might actually have a underlying germline mutation. Certainly bilateral, I fully concur that bilateral Pheos are, have a hereditary condition unless otherwise excluded. Family history is reliable in things like MEN2 and VHL, but it's less reliable in things like SDH related mutations for paraganglioma. Very often they can be very indolent and silent, and so family history may not be very useful, and as a result of that you may not get the typical story of multi-generations being affected, multiple siblings being affected. So when do we actually offer genetic testing as a principle, as a practice? It's firstly, if you do suspect a hereditary condition that's been identified in the family, you would offer it to the other family members. If the personal or family history are suspicious of that, and we'll go through in Pheo what are some of the suspicious features. If there's available genetic testing with sufficient sensitivity and specificity, meaning that the test must actually be robust enough, and for all the ones that we mentioned earlier, for VHL, SDHB, CD, RET and all, the testing has been around for a long, long time, and it's been very robust. Some of the newer genes, it's robust in terms of in the panel testing, in the next generation sequencing panels, we can identify them, but the actual curation of the variants and understanding what that change in the gene is actually doing in terms of impact on function is actually not quite so clear. And so in that sense, many folks do not really want to do a very broad panel for this group of patients, but more focus on the ones where there is more definitive management. The other thing is that if the test will impact on the individual's diagnosis management and you actually have a guideline in terms of how to manage them, that's when really we should be offering genetic testing. So for some of the newer genes that have been associated with Pheo and paragangliomas now, mostly those have been done on research setting and not so much in the clinical setting. So quickly, I'm going to transition over to just talking about neuroendocrine tumor predisposition. How often are they associated in the various neuroendocrine subtypes and some of the known neuroendocrine tumor predisposition syndromes, and who should be referred. So as I mentioned, I love endocrinology tumors because it's very tumor specific. It's very based on the tumor, what is the underlying biology. So Pheo and paraganglioma, as was already mentioned, about 40-45% of them can be due to an underlying germline mutation. This is a list. Clearly, VHL is a very common one. MEN2 or RET is common. Paragangliomas as a whole group is common. NF1 actually is not that uncommon, and there's some of the other ones there. But if you look at parathyroid adenomas and all, RET, of course, can be a cause of that, but 95% of them are actually sporadic. If you look at medullary thyroid cancer, which is the other one where based on histology alone, you should be testing all individuals because up to 25% of them could carry a RET proto-oncogene mutation or MEN2. For things like small intestine neuroendocrine tumors, by and largely they are sporadic. For some of the rest, very often we do not test unless there are some other features or any other family history within that suggests that it's syndromic MEN1 or VHL. But Pheo and medullary thyroid cancer, just on the basis of histology alone, testing is recommended. So I think we've already gone through some of this. So pheochromocytomas are tumors that arise from the adrenal medulla. Paragangliomas can be sympathetic or parasympathetic, as Professor Young has just mentioned, and up to 40% of them are associated with the underlying genetic cause. For MEN2, the hallmark feature is that majority of them actually have medullary thyroid cancer. The thing about the medullary thyroid cancer is that typically the onset's younger than the general population, much more likely for them to be again bilateral and multifocal, and they are underlying in the histology when they're removed, they're often associated with C-cell hyperplasia as well. These are caused by pathogenic variants in the RET proto-oncogene. And I have another slide after this to show you that that's very, very good. It's a classical case of discussing genotype-phenotype correlations, because based on where the mutation is in the RET proto-oncogene, you can get very different clinical manifestations of them. Classically, they're called type 2A, where majority of them get MTCs, fails in 50% of patients, as well as parathyroid adenoma and hyperplasia. A much less common form is type 2B, where they get a very, very early onset of medullary thyroid cancer. Fails are also common in this group, but they also have other physical exams like mucosal neuromas and other facial features. Familial medullary thyroid cancer is in patients where you have a RET proto-oncogene and there's a strong family history of MTC in the family, but there's an absence of pheochromocytoma or parathyroid disease. And in families like this, the worry is mostly limited to the medullary thyroid cancer incidence, but less so for the other phenotypes. So this is a very useful diagram that I show my trainees. So RET is a proto-oncogene, it's a tyrosine kinase, has a intracellular tyrosine kinase domain. And what happens in RET is that if you have mutations that directly switches on, or it's a gain of function mutation in very specific codons, these are actually associated with the highest risk, and very often these require very early intervention, including prophylactic thyroidectomy in infancy, which is one of the recommendations for this group of patients, as opposed to mutations that are happening much more in the cystine-rich, the extracellular domain. This impact on the actual underlying switching on of the RET proto-oncogene much less, and as a result of that, its phenotypes are usually more moderate and does not require as aggressive strategies. From a VHL, if we switch across to VHL, von Hippel-Lindau syndrome is caused by VHL gene, characterized very much by hemangioblastomas. In almost every individual, you will be able, if you hunt you will be able to find some form of hemangioblastomas. In particular, in the retina, 70% of patients with VHL will have some form of retinal lesions, and usually it appears in the second decade or so. The pheochromocytoma, again, is a clear feature. Typically, the pheochromocytomas, as I think you saw in Professor Young's slides, one feature of it is that they tend to be younger. They tend to be in either the first decade or the second decade. Less common for them to just randomly appear in the 50s and 60s. And quite often, patients actually may have a history later on of actually having some hearing issues, which could be due to endolymphatic sac tumors, and something to be looking out for. The one thing about these patients that we do need to monitor them for the risk of actually clear cell renal cell carcinoma later on in life. In the context of having coming in with fail, that's often at least in our practice, that's often the first thing that we see in patients, the early onset ones, which are when they're referred in their because of the young age of fails, and then we need to monitor them, follow them up for renal cell carcinoma, which the RCCs do not tend to predate the pheochromocytoma in the context. So if they do appear together, they tend to come later on. In terms of the other sort of features that may be apparent, including pancreatic cysts, pancreatic neuroendocrine tumors, but it's a very wide range. It can be seen in up to 20% of patients, but some patients actually do not have any. One of the challenges with managing this group of patients is really monitoring and managing the pancreatic neuroendocrine tumors. Our radiologists are very unhappy with us whenever we scan these patients, because it's quite tricky to sort of say when do you need to actually do something and when you can just leave them alone. If I switch gears to head and neck paragangliomas, most cases of head and neck paragangliomas have a genetic cause. The solitary tumors actually have a genetic cause in as high as up to 35% in some series. The bilateral, again, this is where if it's bilateral, there's a higher likelihood that this could be due to a germline cause. In particular, carotid body tumors, if you're bilateral, you should really be suspecting this, that there is underlying genetic reasons for this. The most common genetic changes as associated with hereditary extra adrenal paragangliomas are the succinate dehydrogenase genes, SDHA, SDHB, SDHC, SDHD. There are some differences in terms of how they present, with C and D typically thought to be more affecting the head and neck. SDHB can be affecting a lot of the extra adrenal paraganglioma across the body, including things like the bladder and the rest of it. SDHB has traditionally been thought of as to be higher likelihood of there being a renal cell cancer risk, as well as a higher risk of actually for a more malignant aggressive trajectory. And so we do actually manage these patients, although we don't manage them differently in terms of the guidelines, we are differentially suspicious of different things with them in terms of a gene phenotype correlation. TMEN 127 and MAX are less common, and actually in Singapore we have one MAX case, but we haven't seen a TM127 case as yet, so they are very much less common. The other genes that can be associated are including neurofibromatosis type 1. I think it's worth mentioning them because they're actually very common in the population. 1 in 1,000 individuals actually, 1 in 2,500 individuals actually have neurofibromatosis type 1. And although Pheo is not a very common presentation in the patients with NF, but because they are around, we should be aware of them. And if there is early onset hypertension in this group of patients, it's very worthwhile to consider screening for Pheos in this group of patients, just in the off chance that this could be due to that. There are two other genes that I think Prof Young has also mentioned, which is EPAS1 and FH. And just worth mentioning that if you do notice that there is polycythemia in your patient with a paraganglioma, you do want to consider EPAS1 as a differential. And then the other one is if it is in the context of renal cell carcinoma in the history, fumarate hydratase is another gene that one needs to be aware of. Again, just to reiterate if you dive a little bit deeper into the various SDHX complex related mutations and their manifestations, the most common that we might see is either SDHB or SDHD globally, and you can see that the other associated cancers for them are renal cell carcinoma is the most common one. But both SDHB and actually SDHA, I apologize for SDHB not having GIST there, we do see GIST associated with them as well. And again, I think even with this table, our experience with the SDHX group is actually also growing. The penetrance of disease, etc., as I'll show you in some further slides, there was a publication about it, and more patients are being collected now for us to better understand the penetrance, the genotype-phenotype correlation. So this would likely still change. Although for VHL and RET, I think we're quite comfortable. At the moment, they're not that clinically applicable because we haven't quite yet figured out, what are the management or follow-up guidelines that are required for this group of patients. It's enough to say that in the patients who test negative, and that you are very suspicious there's still a germline component, then it's worthwhile enrolling them in clinical studies. So we have a clinical trial ongoing where we are doing long-read sequencing for all our paragangliomas and Pheos in an attempt to find out what else is going on, what are the other genes that are causing, that could be underlying the predisposition. In terms of inheritance pattern, most of the conditions that has been discussed so far are inherited in an autosomal dominant pattern, which means that first-degree relatives, siblings, and parents, and etc., will have a 50-50 likelihood of actually inheriting the mutation and therefore manifesting the disease. There are some conditions like SDHD and SDHAF2 where the risk is higher if it's inherited paternally due to maternal imprinting. For all of the conditions, both the maternally imprinted ones as well as the autosomal dominant pattern ones, recommendations are that all first-degree relatives should be screened and should be tested. So we would offer cascade testing to everybody. So some of the screening guidelines, the one reason why I haven't gone too much into the screening guidelines is because access to them are very variable in Asia, and a lot of people are doing just what they can rather than just following strictly to those guidelines, but so I won't go through the specific ones which you can find on the websites and all, but mostly more the principles. The idea is that we want to try and identify these people earlier, but there is significant considerations of cost, time, and the risk benefit and anxiety. I'll show you a case later of a patient where this came up. For the well-established conditions like VHL, MEN1, MEN2, the guidelines are updated periodically, but very much they've been quite static for the carry that particular variant that will go ahead to express that associated trait. So complete penetrance is something where if you have the pathogenic variant, 100% of you would develop that disease trait. Incomplete penetrance is that if you had that mutation, only like 10%, 20% of you, and which 10, which 20, and at what time point for SDHX related disease, that's still being defined at the moment. And this is one paper that was published recently that looked at the risk estimates based on affected individuals, probands, but there's a little bit of bias because probands are people who actually show up with already the disease. The true risk estimates will only come if we have data from unaffected family members and follow them up over time. So it's likely to come down as well over time. And we've seen this with all other hereditary cancer conditions. But right now, based on that paper and others, the estimated penetrance or lifetime risk for individuals with SDHA mutations is about 10% of developing another paraganglioma. For SDHB is 22%, SDHC 25%, higher for SDHD 50%. But again, this is something that will evolve with more data that's coming along. So in general, all Pheos and paragangliomas and all medullary thyroid cancer patients should be offered genetic testing. Right. For medullary thyroid cancer, it's for the identification of red proto-oncogene mutations. For Pheo and paragangliomas is usually done as a panel so that we can try and detect one of the various conditions that we just spoke about. So I'm just going to quickly run through. So if you've been referred to genetics, what actually happens? They go through a review of the history, the family history, physical exam, a discussion of the pre-test, counseling for the testing and a post-test counseling. Blood and saliva can be used for diagnosis of germline mutations. After the test has been done, and if something's been identified, there's a post-test counseling session where the management plans are discussed with the patient and the family members, and then we organize for familial testing. We would test for the same variant in the family members, in the siblings and the parents, and then depending on the gene that's involved, what age do we start surveillance and screening will be based on the sort of gene-specific guidelines. We do actually go over also the inheritance and the reproductive options for patients. In Singapore context, some of the conditions are eligible for pre-implantation genetic diagnosis with IVF, and that's what some patients have opted for as well. If you actually undergo genetic testing and you do not get an informative results, meaning that it either come back as an unknown significance or a negative result, what happens? Usually we will continue the management based on the clinical and personal history, as well as the family history. And sometimes we do review this and sometimes do offer genetic testing. If let's say is that majority of them actually do have a family history, but only barely, 53.6% of them. 90% of them actually agreed to go for testing. And about our mutation positive rate is about 34.5%, which is right around the mark. I run an adult service, so I do see more of the adults, so that's one of the reasons why it's maybe not be as high as the 40%. And our most common one is SDHD, SDHB, followed by the rest. And we do have some recurrent founder mutations in both SDHB and SDHD in the Singapore context as well. So I'll skip through that. So some of the future directions in terms of the management, there's already now belzutifan for VHL-related RCC. We do have a phase 2 trial now at NCC for VHL-related cancers other than RCC. So if you have any patient with VHL-related cancers other than RCC, you can refer them. SDH8-related GIST, you can refer them as well for this VHL trial. There are available MEK inhibitors for NF1-related tumors, RET inhibitors for RET-driven tumors, surveillance changes. I wanted to ask Bill whether to use whole body MRI at all in Mayo, but this is something that we are toying with the idea, and we have actually done it as a research study, and it's been good so far. But again, the data is not quite sort of consistent in this regard. There is definitely an increasing demand for pre-implantation genetic diagnosis from young patients, because they are very young and they are childbearing age, and they have been asking for this in the Singapore context. Be worthwhile to discuss this in the ASEAN context. We do need a better understanding of the contribution of epigenetics to the field of pheochromocytoma, which is not genetic mutations itself, but other things that actually turn on and off these genes that can drive pheo and paragangliomas development. So just very quickly, we have this young lady, she's 33-year-old. She developed pheo at 21, and she was referred to us. And she came, as what we have been saying, the younger ones, VHL is a common gene that's involved. So VHL, she was VHL pathogenic variant positive, and we've been managing her for the last 12 years. And over the next decade, she kept trying to get pregnant. And it's very and it's both a success of her management plan, also so in a way non-success of a management plan, because every time she started family planning, she comes for a scan, and then something will get detected. So she had 2 renal cell carcinomas in stage 1 resected over the course of this 10 years. And the good news is they were all stage 1, and she's well from that. And so after a very long, difficult time, she managed to actually get successful PGD and implantation. A couple of things to highlight is that, at least in the Singapore context, our anesthetists were very, very unhappy to do a normal vaginal delivery for her, because they were worried for occult hemangioblastomas in the brain. And the patient was very upset because she really wanted to have that. And she didn't have any lesions in her brain or imaging. So we had to really convince the anesthesia that it was actually okay to go ahead with a normal vaginal delivery, because the imaging was clear. And it's also not that clear what the sort of the perioperative guidelines are in terms of what size lesions, and you mentioned about make it risky and not. So these were things that were being considered post-op. All her lesions, of course, we had to do a lot of reassurance and sort of say this is unlikely that, we just monitor it. But it could be equally likely that someone saw that, and if they're not aware of this phenomenon, would have recommended that surgery is done, etc., etc. So it's very important that people are mindful that some of this is just hormonal changes and you don't need to do anything about it. Of course, there are questions of her other lesions. Is belzutifan an option? But I don't think we have time to go through this. The child is a PGD implanted child and is therefore wild type for VHL. But unfortunately, insurance still considers the newborn VHL because of the family history. This is something that we're fighting our insurance agents about, because technically the child isn't, but this is something that is an ongoing issue. Very much similar to what ANAH is. There's another, we are part of another SCRI project where we are sort of trying to improve care and research and education around Asia for all her inherited cancers, in cancers, not just PHEOs and PCCs. So I welcome anyone here who's interested to write to us to find out more. Just a bit of a plug. In January in 2025, there are 2 symposiums, and I'll make sure that these are sent out to maybe the network here if people are interested. Professor Hamid Newman, another luminary in the field, is also coming to Singapore. This is a little bit of as I mentioned earlier, in memoriam for my former mentor. So this is an in memoriam, a series of things that were put together to actually honor her contributions to the field. And also just to say that we run a genomic medicine fellowship. We fund one of our fellows is actually in the audience from Bangladesh today. We believe very much in training clinicians to be sort of comfortable with the field. And so there's 1 funded position a year, and people are welcome to write to us to come for practice in the clinic. So in summary, the majority of cases of neuroendocrine tumors are sporadic. However, genetics evaluation should be considered in anyone with paragangliomas or PHEOs, up to 40%, as you've heard multiple times now. In addition to that, anyone with medullary thyroid cancer also should be considered for genetic testing. You should look out for syndromic features of MEN1, MEN2, or VHL. Multiple primary tumors, for sure, you should actually offer testing. Family history is the other big one. Although I just have to warn you that the paraganglioma group very often do not have, the SDH group very often do not have a strong family history. The gene mutations are definitely useful for clinicians from both a prognostic as well as management decisions, and there's active research ongoing. So I will stop there. Thanks.
Thank you very much, Joanne. That was a very useful talk. I think for most of us endocrinologists practicing, we probably could think more about the hereditary component, and it really works. It really helps us. I mean, personally, you have helped me a lot with my patients with pheochromocytomas who do need to get genetic screening. So I think that's a very important message.